what's the next vessel?
The aorta.
Louder, aorta, right? And then from aorta to the different arteries, right? So because that stretch and the elastic wall will then eventually, they will snap back, that propels the blood forward. Does that make sense? It propels the blood because, I mean, you kind of have to keep going, right? Down the circulation. So this is the important part, the pressure reservoir. The other important part of this figure is this arterioles, which is the smaller branches from the arteries, is the one that is really under influence of sympathetic nervous system. The sympathetic nervous system, as you can imagine, will have very little control over aorta or major arteries. I mean, to change diameter of those vessels is not happening. Where the diameter is changing, constriction and dilation, is at the arterioles level. So that's where the constriction and dilation based on sympathetic nervous system release of noradrenaline and adrenaline is happening. So that's an important point of this. Of course, you know the capillaries is the exchange between the arterioles and venules. That's where the exchange of the nutrients takes place. There is hardly any exchange in arterioles, arteries, aorta. It's more like just a delivery of the blood. So the exchange is here between the tissue. These yellow cells represent the tissue. It could be any cells, vascular, pancreatic cells, skin cells, what have you. Between the cells and the vascularization happens in the capillary level. We'll talk a lot about that. What exactly is the exchange take place? And then blood gets deoxygenized, and that's it's blue because the CO2 entering the circulation here, and a lot of oxygen moving towards the cell, right? So the blood that flows in the venules, we call it deoxygenized. It's not, of course, void of oxygen. It just has less than the arterial. And then it finally collects. But then, here's another point that I was just mentioning to you. Large veins are expandable, and they can hold a lot of blood. And we call them volume reservoir, till they eventually drain in the right atrium. So make sure that you follow the description in this figure and you understand this, internalize it, that would be useful. So this is where you pay attention a little bit into the difference between the arteries, arterioles, venules and veins and capillaries. Look at the arteries. So the fibrous tissue, connective tissue, pretty prominent. The muscle, the smooth muscles, also a very, very thick layer. And look at this elastic tissue, very strong elastic tissue, and of course endothelium. Endothelium is quite similar everywhere because it is a really single layer of the endothelial cells. So in that respect, it would be similar, except some will be more leaky than the other, like in capillary. As you can see, it's really just the one cell. And that's where the exchange takes place. So it does make sense for the capillary not to present too many barriers for the exchange, right? And then as we're going down to venous vein, connective tissue is there. Muscle is less than in the arterial wall, and then in the large veins, also a smaller amount of the elastic tissue that's in the arteries. So as you can clearly see, the arteries are the one that's most kind of sturdy and can sustain a lot of pressure from the blood, which makes sense because it also where the highest blood pressure is experienced, the aorta and the arteries. Because remember that we saw in the previous, how the pressure drops going down. So as I mentioned, the exchange of the nutrient and gases does happen at the capillary level. We don't have the elastic tissue, we don't have the smooth muscle tissue. It's quite leaky, so one layer of the endothelial cells. The basal lamina is very thin layer of the matrix. Some areas, but not all, we have an additional cells called pericytes that they associated with some capillaries. And as needed, they could decrease the permeability, because if you think of just one layer of endothelial cells, it's very leaky. But in the blood-brain barrier, remember the astrocytes were actually working as the pericytes. When we're gonna get to the kidney, where the filtration of the blood happens, there will be also pericyte playing the role, and some other tissues. So the pericytes is these cells that kind of reddish in color here, and they kind of offer additional protection from the leakage. But they're not present everywhere, and some tissue lack any pericytes at all. Okay, so between arterioles and the small venules, this is where we call capillary bed very often. They do have small sphincters. They can control the diameter. They can also create what we call anastomosis, meaning like the connections if the tissue is growing, or if it's tumor grows, or if it's gaining a lot of weight. The capillaries are able to create additional vessels to continue to supply growing tissue with the nutrients. The term that we use to describe the development of new vessels is called angiogenesis. Some organs go through the angiogenesis on a regular basis, like during the period. The uterine lining gets very thick, and there is a lot of new vessels preparing for potential implantation. During endurance training, of course, tumors, they are notorious for angiogenesis, and one of the key pharmaceutical intervention is to figure out a way how to stop the growth of the vessels, because then the tumor will kind of starve itself. So there's a lot of different factors. You don't really have to memorize them, but I decided that I'll just mention them in case you hear about them. And collateral circulation often develops if something's blocked, like the main capillaries or venules or arterioles are blocked. The body could develop additional collateral circulation to continue to support the organ. So let's talk about blood pressure now. So a few things that being currently measured on a regular basis. The blood pressure, as we know, is diastolic and systolic. Pulse pressure is very important, because if you think about it, so the pulse pressure is the systolic minus diastolic. This is sort of like a driving pressure, right? It's like kind of discriminates the differences between the systole and diastole, and just says, well, this is what the driving pressure of the blood is, like at any given moment. As we know, the valvature one way. So this one, the mean arterial pressure, that is calculated by diastolic pressure plus a third of the pulse pressure, is very often referred also as a driving pressure, but it's kind of like how well the organs are perfused. So a lot of cardiologists, even they may be measuring just the blood pressure, but their software calculates the mean arterial pressure, because it's a better way to know how well the organs are perfused, how much blood is delivered to the organ. The sphygmomanometry is, of course, how we do the measuring the blood pressure. Okay, we'll talk about Ashley's question in a bit. So we do know that ventricular contraction will create the flow of the blood into aorta, where we would experience the higher pressure. The aorta and artery will expand to accommodate the blood, and that pressure will be stored in the wall of aorta as a potential energy. Thus the name, the pressure reservoir. When the ventricle relax, the aorta and arteries recoil, and the recoil meaning like after you stretch, it kind of goes back a little bit, not completely, just kind of back. And that, blood has to go somewhere, right? Semilunar valves are closed, can't go back to the heart, has to go forward. And that is what ensures that we actually have the driving pressure, the flow of the blood. So the highest pressure is in arteries, decreases away from the heart, hopefully understanding, because we are going down the pressure gradient, right? And then systolic pressure is during ventricular contraction And the diastolic pressure is during ventricular relaxation. When the pressure is low, a few concerns, right? So it's a poor oxygen delivery. And very often, one of the first signs is the dizziness or fainting. Because brain, does not do well in a hypoxia, does not do well at all. So the low oxygen delivery to the brain will usually cause the dizziness or fainting. Sometimes people will get quite dizzy that they can actually lose the consciousness. So that's the low perfusion. The term perfusion means how much blood is supplied to the organs. Perfusion, how well they're perfused. You will have to be severely dehydrated, and meaning like the blood volume was so low that would also lead to the low blood pressure. Various medication, of course, severe blood loss, right, was all lead to the low blood pressure. With the high blood pressure, as you guys know, high salt diet, but also actually high sugar diet as well, because both salt and sugar retain water to keep osmolarity. Making sure the osmolarity within the homeostatic range, it will not allow water to be excreted by kidney. So you're gonna increase the volume, right? And you guys know when you eat something salty, you usually seek water. But and on top of that, you also not peeing too much. So you have a lot of volume, and that volume will increase the driving pressure of the blood. Same with the sugar. I didn't put it here, but same with the sugar. So the high fat diet, theoretically, some fats, as you know, saturated fat, could have a buildup, and then what that does is that atherosclerosis is a thickening of the wall, creating the diversion for the flow, and that also increases resistance, because now, instead of more smooth gliding along the walls, now you have like more deformed or partially narrowed blood, and that will increase resistance and it will increase the blood pressure. Of course, sympathetic nervous system stress will lead to more norepinephrine, and more epinephrine will vasoconstrict and increase pressure. The concern is, of course, many the hemorrhages, stroke, aneurysm, ruptured vessels. That could be all the reasons to very high blood pressure that's not controlled. Kidney damage is very, very important one, and actually lately it's becoming quite a concern, because over time, if the high blood pressure is not controlled, then when we get to kidney, you will appreciate that the way the nephron is where the filtration of the blood happens in the kidney is very gentle, very fragile organization. So when you constantly have very high blood pressure at which the blood arrives to that nephron, over time, it's damages. Kidney do have quite a serious ability to sustain their function. You could lose like up to, as long as you keep like 20, 30, I've seen different data, % of one of your kidney, it will still work. But the damage to the glomerularitis is not the glomerular would actually could lead to the serious disorders. Okay, so this is just speak to the point that we said, like contraction, expansion, and then of course after that it will be recoil and push forward. Pressure reservoir and elastic recoil is the term when they snap back and allow for the blood to go forward. It makes sense, right? So it's just another way of showing the blood pressure. Sphygmomanometry is based on what we call a Korthoff sound by the name of the physician. And the idea is the simple one. You just put in the air in your cough till you stop circulation. Radial artery often use, but it could be, of course, anywhere. Closer to the heart is better, so most people would put it around the radial artery. And so you will stop the flow, and then as you release the pressure, right, eventually you will resolve the ability for the blood to flow through, right, as you're decreasing the pressure. And so that blood flow, that first movement will create a sound, we call the first Kharkov sound, and that would be your systolic pressure. And then you continue to release the cuff till flow resumes smoothly, and there's no more sound, and that would be diastolic pressure. You'll do it in the lab. There was a bunch of other experiments. So, factors affecting blood pressure. We already discussed the blood volume. So, gaining a lot of fluid, retaining a lot of fluid, losing a lot of fluid, that would be a factor, right, in the blood pressure. How effective the heart is as a pump. How much volume is released per beat, which is what we call stroke volume, directly correlates with the power of the ventricular muscle if there is a previous infarction or other weaknesses of the heart, and then the heart rate. Diameter of arterioles also a very huge factor. Constriction will lead to high pressure, dilation will lead to lowering the pressure. That's why very often people with the high, like, I mean, not like it wouldn't be like a normal fix, it would be just in the moment, taking a hot shower, right? And trying to decrease the volume of superficial vessels and kind of redistribute the blood away. Putting like a hot compresses, different places, again, could dilate the arterioles and kind of take the pressure off a little bit. And then also relative distribution of the blood between arterial and venous blood. And what I meant by that is what I referred to you earlier. So if I'm holding a lot of blood in my veins, so how do you think it will affect the blood pressure? So it depends when we're going to measure that, right? So if I am holding a lot of volume, that is actually decreases the volume, and it will decrease the pressure. And actually, when you were talking about why sometimes we want to take the measurements of the blood pressure standing up, especially in elderly, I think you mentioned, right? So there's quite a few factors going on. So one of the things that we sometimes refer to as orthostatic hypotension is when the people stand up. Of course, the blood flows, right? But normally, the sympathetic nervous system should realize that the pressure is falling and activate sympathetic nervous system to constrict and keep the blood pressure up, normal. Because remember, they're keeping it in the homeostatic range, right? But in the elderly people, that does not happen very well. Very often, when you take their pressure sitting down, and then when you take it standing up, the difference, standing up is much lower. Which understandable, because the blood is flowing down their legs, and so they had less in the circulation, less return to the heart. Yeah, less return, because it's in the vein, so the vena cava brings less blood, less, smaller stroke volume, and the blood pressure will low. But normally, body should be able to, within a few seconds, instruct the arterioles to constrict and bring pressure up. Because if you're losing blood pressure, remember fainting, and especially elderly, they can fall, sorry. So that is one thing that they're looking for, to see how quickly. So they diagnose in orthostatic hypotension. Orthostatic, change in the position, standing up, hypotension. That's usually an elderly. But what I noticed lately is there was a lot of research about doing this sitting up and standing up and actually experience orthostatic hypertension. Meaning like you standing up and your blood pressure is actually higher. And that actually seems to correlate in the younger adults with the early detection of hypertension. That's an indication that their system, especially sympathetic nervous system, is on overdrive, like very active. It could lead. Because there was a big study, I remember, like they started in the 90s, but then they followed the people for many years. And they said the one that had orthostatic hypertension had more severe cardiovascular events. So that's another diagnostic criteria that kind of seems to be getting the momentum. But for the one that you referred to, the elderly, that was well established that they don't compensate very well for low blood pressure. And so we could then advise them to say, when you're getting out of the bed, make sure that you're very carefully, don't get up, sit down on the bed first before you. So diagnosing orthostatic hypotension by seeing that when they stand up, the blood pressure drops and they're not recovering, because they should recover within a couple seconds. So vasovagal syncope, that we refer to as fainting because of the low oxygenation of the brain. It could happen not only when you have a sudden drop in the blood pressure, it could also, it could happen for many reasons, I'm gonna say. One of the reasons actually is very well described is when you experience event that is very frightening. There seems to be evolutionary research suggesting that when you're in a position, let's say you saw blood or you saw something that very disturbing to you, people could faint. And what that is a very quick activation of parasympathetic nervous system, slows the heart rate, leads to hypoxia and fainting. But it looks like it's evolutionary adaptation to take you out of a situation. Because now everybody has to attend to you, right? And you're not experiencing whatever that you didn't want to experience. Did anybody ever fainted? What was the circumstances? If that's okay to say.
I think they gave me some drug.
Okay, so it was a drug induced.
Yeah, I was very, very young, maybe 13. I don't remember what it was, but it made the blood flow go
The blood pressure.
It was a Sinopen and it was on.
What's the active ingredient then?
It was allergy.
Okay. So that was a drug induced, okay. What about your situation?
Me, I was pregnant. I had very low iron. So whenever I stood up,
So that's a hypoxia, yeah.
Mhm.
Did I see it?
I just had a question. I don't know if it's related or not, but do you know why, when some people get their blood drawn, they faint?
That is actually vasovagal syncope, parasympathetic activation, and then slowing heart rate, hypoxia is the result of the brain. And that's the one what I was referring to, that there is a lot of research saying there's actually adaptation. And it doesn't have to be that bad as the blood, right? Because I fainted once in my life, and I'm pretty sturdy, but it was just like the ear piercing went wrong, and there was all this inflame and stuff like that, and I couldn't touch my ear. It was like this hideous inflammation there. It was a nurse who poked me with the surgical needle. It was an inoffensive salon. So anyway, she infected it. And my mom decided to squeeze on it to release the pressure or pus, whatever was there. And I was like, sliding down. And it wasn't that painful. I think it was just, I don't know. Anyway, I think I saw another hand. What was that, Danielle?
I fainted. I was at cheer practice and it was really hot out and we were in the sun all day.
That's most likely vasodilation and low blood volume. Yeah, hypoxia would be the reason of fainting, right? But you can get to hypoxia in many ways.
I think it was in response to pain. I'm kind of wondering what the evolutionary advantage to that would be. You think pain would, you'd want to stay awake?
Well, are you okay to say what kind of
It's
pain?
like a procedure. Like,
Yeah, because that it just kind of increases attention to you though, and you don't have to experience it. But usually people start fussing and doing something, right?
But I feel nobody likes that attention.
Um,
You know, after
it's a very severe. It's like your body is showing that you are not okay, right? So that allows people to do more for you, right? Or take you out of situation, because you would recover, especially when you fall down. The blood flow will increase to your to brain, and you will recover. And unless you hit something, of course. That's a separate story.
So like the other day, my mother-in-law called me and she was on a ladder and she had been pulling oranges off her tree and the ladder started wobbling. And so she grabbed onto the tree, but once she stabilized the ladder, she got down and she sat down and just passed out. So is that kind of the same situation?
So she also had, so potentially,
Because it
she
scared the
could have
life out of
actually
her.
suffered orthostatic hypotension. Like a lot of pulling in her blood.
from like
She was
walking
standing up, right?
Yeah,
she
she
was
was on the
standing
ladder
up a lot.
standing up and then
she
she
was
got down
peeking,
and just,
so everything away towards gravity. So
Yeah.
low stroke volume, low venous return. She could have just suffered hypoxia
okay.
because of redistribution of the blood.
It's so funny that you can like pee yourself or even like poop
Oh, yeah, that's
when you're
hilarious.
fainted.
yeah.
I mean, it's not funny, but it's, I'm
No.
saying it's a thing, and a lot of people are having a lot of like, you know, kind of anxiety with that. Like I've been talking with people because it's my anxiety, like fainting. After I experienced that, I always think about it. Imagine it happens again. Oh my God, you know. And I'm an anxious person in general, you know. But
We
when
all
somebody,
worry to a different degree.
I know, yeah, but when somebody told me about that extra, that the sphincters kind of release and everything. that was
Parasympathetic
like,
nervous
that
system.
was like extra scary for me.
Parasympathetic nervous system,
Yeah,
right?
it happened to many people. My mom happened to my mom.
Okay, guys, so we talked about PNS and SNS, and we mentioned that arterioles, one of the exceptions of the antagonistic control, right? We said that they only have receptors for norepinephrine and epinephrine. They're not controlled by parasympathetic nervous system. The heart rate is controlled by parasympathetic and sympathetic nervous system, because there are both receptors and the outer rhythmic pacemaker cells. But arterioles do not have receptors for acetylcholine, so they only respond to epinephrine or epinephrine. The name of the receptor is different. That in the pacemaker cells, there's a beta one, and this is alpha, but it doesn't matter. It's a different structure of receptors, but they are receptor for norepinephrine and epinephrine. So then how do you vasodilate and vasoconstrict if there is no antagonistic effect? It's only based on less or more. So more norepinephrine, vasoconstriction, less norepinephrine, epinephrine, vasodilation. So it's a tonic control. There's always some kind of a discharge of the norepinephrine, epinephrine, so less or more. That's very different, right, from the other antagonistic effects of parasympathetic and sympathetic nervous system. So make sure that you understand this and also know the name of the receptors, alpha receptors. In the brain stem, there is an area called medulla oblongata, and that area of the brain stem has a lot of nuclei responsible for controlling different things, like a breathing center and the cardiovascular control center. So cardiovascular control center is located in medulla oblongata, and it's a cardiovascular control center that controls sympathetic and parasympathetic nervous system effect on the heart. So that's the boss. The cardiovascular control center is the boss, right? So if it activates parasympathetic neurons, they will discharge acetylcholine to a say node, and the heart rate will parasympathetic.
Oh, parasympathetic decrease.
Decrease. If the cardiovascular control center activates sympathetic nervous system, it will increase the heart rate. It will actually change the vessels diameter. See, parasympathetic doesn't have an arrow to the veins and arterioles, mostly arterioles, but the vein to a certain degree as well. The carotid arteries and other arteries, but the carotid has like a main conglomerate of the baroreceptors. Aorta has also baroreceptors. These are tonically active baroreceptors that always measuring the blood pressure, and that's the stimulus, the afferent pathway to medulla oblongata cardiovascular control center. Because how's the cardiovascular control center will know what's up with the blood pressure? It's a baroreceptor's job to tell medulla oblongata cardiovascular control center the blood pressure high, the blood pressure low, and then the cardiovascular control center will either activate parasympathetic or sympathetic nervous system to try to bring it back to homeostatic range. Okay, so baroreceptors will sense the change. So in the aorta arch and the carotid will sense the change in the pressure. They are the sensors. Afferent pathway to medulla oblongata, and then efferent pathway, and therefore response of the vessels and the heart. That's the pathway. I put a little bit of a reminder here. SA note, muscarinic for acetylcholine, and beta-1 adrenergic for epinephrine, norepinephrine, yes? That's on the pacemaker cells. Ventricles also have beta-1 receptors for epinephrine, norepinephrine. And that's what that line is. And specifically the pacemaker cells. AV node, branches. And of course, arterioles and vein, alpha receptors, adrenergic for norepinephrine, epinephrine. Please make sure you have these notes on your cheat sheet. And actually, cardiovascular control center, maybe the arch. You don't have to do that kind of drawing, but you could do like baroreceptor in aorta and carotid artery, cardiovascular control center, medulla oblongata, sympathetic, parasympathetic, efferent pathway, and then the receptors. Discharge of norepinephrine or acetylcholine. Very good figure for you to make sure you have it. Okay, so we mostly talked about it, but let's just follow the homeostatic response to a high blood pressure. And of course, that's to the point, as much as the body can do. So the blood pressure is high, yes? Receptors are called what? Yeah, baroreceptors in the carotid artery and the aorta. The afferent the sensory neurons to cardiovascular control center and medulla, yes? So if the blood pressure is high, do you think sympathetic nervous system is gonna be activated or depressed? The blood pressure is high. Sympathetic nervous system needs to be decreased. Blood pressure is high. Do we want to vasoconstrict now?
Oh, yeah.
So sympathetic input, arrow down. Less norepinephrine, epinephrine release. Remember, the sympathetic nervous system is like more or less. So then on the alpha receptors, that would be what? Arterioles and veins, right? So what's going to be the result of less norepinephrine on vessels? Vasodilation. So now you have less resistance to the flow, lowering the blood pressure already. But then, less norepinephrine, epinephrine on the beta 1 receptors will slow down the heart rate, remember? Decrease the volume, stroke volume, decrease the cardiac output, decrease the blood pressure